thinking about patients now, we understand the benefits of exercise, but non-compliance and adherence can be quite high when it does come to exercise in our units. Why do you think that is? Maybe we'll start with Stephanie.
So many reasons. So there's the person-related factors of just people are not going to feel well some days. And I think that needs to be always accepted and factored in. People are going to have bad days, or maybe they've gained too much fluid, and we have some protocols for that and so on. But I think like we calculated this one time, and it was the chief complaint was fatigue for person-related reasons for not exercising. You know, again, I think coming back to that, sometimes the exercise can actually help the fatigue. So then as an exercise program to be really good, we would then feed that back and then think about the education when we started onboarded people with the exercise to talk about that. The other reason is staffing. So if the kinesiologist is not there, you can't get your bike. And sometimes the patients have talked about this, they just sense that it's not a good day to ask for that bike. And that happens quite often.
Yeah, we'll pass it off to Jenn next.
Yeah, totally agree with that. That, you know, I'll ask, well, how come you're not biking today when I come around? And they're like, oh, the nurses were way too busy. I felt like I didn't want to bother them. So there is a lot of that goes on for sure. But you're right, like fatigue is like the #1 reason why people aren't engaging in exercise. And pain, actually, that's the other thing. There's our patients have a lot of chronic pain. And so sometimes that's holding them back from participating too. So yeah, typical, those are probably the most common barriers, and then the program barriers, the lack of a bike, the lack of a engaged nurse to help the patient. So those would be kind of our main barriers that we still face.
Yeah. Any different barriers in Winnipeg?
Well, no, I agree with all of those. I just would say that, like, you know, also we're talking about humans. So, you know, as you guys know, I'm a very dedicated exerciser, but this weekend I was on call and I was tired, and my exercise adherence for my week, what I usually plan to do, is at 30% at the moment for this week. So, you know, it's also just human nature. If you look at the compliance in the general population, it may be a little bit better, but it's really not that much better in the general population.
Yeah. Great points. So switching gears a little bit here. So do you think that exercise in chronic kidney disease, particularly in a clinical care setting, is a priority? Why or why not? Jenn, let's start with you.
I mean, I think it should be a priority. I don't know if it actually truly is in all programs or even in my own program. And the reason I think it should be a priority is because people feel better with exercise, honestly. So quality of life is much better, and all of the common symptoms associated with kidney disease can actually be improved with exercise. So for me, it should be part of our treatment, our approach to chronic kidney disease, and how to help our patients, like just pure and simple. So I often, I know it's a total cliche, but seriously, exercise is that little magic little pill, right? Like it should be just something we prescribe, something we talk about, encourage to all of our patients, just like full stop.
Clara, let's swing it up to you.
Yeah, I agree with all of that. I just would also say that there is evidence that it improves mental health as well in people with kidney disease, not just in the general population, which is a huge issue. So frailty, physical function, mental health, those are all things we have no other treatments for in kidney disease. And it has been shown to improve all of those. So I think I think it should be used for that. And I think maybe Stephanie might want to talk about this too, but I really think we need to move away from just exercise is good for you and you should do it to, you know, you have restless leg syndrome and during dialysis, and exercise is actually a proven treatment for that. Why don't you cycle on the bike, and why don't we see how your restless legs and is is improving or changing with that. So it's actually a treatment that you apply and you follow what the response to treatment is, just like we would with a medication. And I don't think we're doing that. I think we should be doing that as a nephrology community.
Yeah, I mean, you know, that's my song, and it drives me crazy when people say, oh yeah, of course exercise is good, everybody should be doing it. It's like, well, they're not, and they're not being prescribed it for a specific outcome. So those are two totally different things. I'm not discounting the value of movement, but being, you know, active in your everyday is very different from actually an exercise prescription with an intended outcome. And so, you know, other people I know, they think like, okay, you can talk about all these things that exercise is shown to be good for, but really I'm a nephrologist. Like I run the numbers, like I'm about dialysis and that's what I focus on. Well, if you at this, like seriously, I mean, I go to home therapies, for example. Think about the most recent article about the association, the trial that showed the association between hypokalemia and increased risk of peritonitis. I mean, one of the proposed mechanisms is that the hypokalemia interferes with muscle function and people can't do their PD. Well, what's good for muscle function? And if you're not saying exercise in your top 3 answers, that's a knowledge gap. So I think it's just that we haven't really recognized the direct role of exercise in actual CKD and dialysis. We just don't learn about it. We don't think about it in medicine. And I think that's always hard for other people to understand too. It's like, well, what do you doctors learn about? Well, we learn about disease, you know, in medicine and so on. We're actually not exercise experts. So we're not always the best people to ask unless you have an interest. So it's a really big gap knowledge-wise, I think, in our discipline. Cardiology, pulmonary, they may have had a bit more just because their rehab is included in their usual care in terms of processes and pathways and standards of care. So I think some of those specialties know what to say to patients about benefits. It's ingrained, whereas we are really just hopefully coming into that more and more over the next few years because it has not been a priority.
And I would say it's a knowledge gap, but also a care gap now. Like there's enough evidence that we should be doing this now.
Yeah, very fair point. So just to round things off here, what would you say is your ultimate goal for clinical and exercise programs in Canada and across the globe? Jen, we'll start with you on this one.
That's a lofty question. Okay. My goal, honestly, would be, I guess, to improve awareness, right? Awareness of the value of exercise in chronic kidney disease. And hopefully the goal would be to increase access, so awareness and access for exercise. And that does require programs putting it as a priority and helping support the people that they need to then build their programs. So, you know, even if you just look in Canada, there is not an exercise program for every kidney program across Canada. Like that's pretty sad, actually. And, you know, do we even have like a Canadian, like at our Canadian Society of Nephrology, do we even have any priorities or guidelines or, you know, consensus statements on the value of exercise for the treatment of patients with kidney disease? So it's like, we have a lot of work to do, I think, for improving awareness and acceptance and making it part of our programs. You know, and now part of that, like, so how can we actually achieve that? I think another way to achieve that, if the policymakers aren't on board, then perhaps we can engage our patients, and with enough empowerment of our patients to push for having exercise built into programs, you know, that can be a workaround approach. So that's my new thing.
Thanks for sharing. Clara, let's get you on the answer there next.
Jen has said a lot of what I also believe. I think there are 2 additional things. One is that if we can help people see that implementation is possible everywhere, so actually having kind of implementation guidelines or toolkits for units that want to start in center hemo, or even you know, I think I don't think in-center hemocycling is necessarily the answer for everyone. I think there should be a variety of programs, and I think that's part of the knowledge translation, is really letting people know that different programs and different exercises can be applied for different treatments and treatment goals. And then the other thing, again, to highlight is just that I think that it needs to become mainstream in nephrology that we talk about this, and it's coming. Like, we all have been invited to talk about exercise, both to the lay public and at conferences over the last couple of years, which never would have happened 5 years ago. But I think it's real, the last time CSN had a plenary session was, I think, in 2013 or 2014. And so Canadian Society of Nephrology, all the societies really need to start talking about it as a treatment. And that would also make it more mainstream and make nephrologists who do have a lot of say in what happens in the units often maybe think about incorporating it into their programs.
Awesome. And maybe Stephanie will finish off with you.
Yeah, much the same. Like, I think locally in our program, our goal has always been that we will be able to provide exercise, counseling, and resources to all people in our program. And I think that's doable. And I wonder too about, combining rehab, like multi-condition, like comorbid rehab. Like, why is it just, pulmonary siloed off together? Can't we combine resources? They're very common aspects of disease that can be improved through exercise there. So, I mean, that would really be innovative to see. And then second, just about this setting the agenda scientifically, I agree. Like, it is getting better, but it's really not on the agenda the way it could be. So you think about KDIGO, and we've been pushing for this controversies conference to really set the agenda for what are the remaining important questions in exercise science and CKD. And we will continue to sort of push that idea, because it's a very interesting concept that includes a lot of the previous interests of the society. So symptom control, blood pressure management, vascular effects, all of these things. So, it's on the radar, but I just think that would be the goal, is to have it on the international agenda, to have it regularly at conferences. Yeah, that would be my dream.
Awesome. Well, what a great way to finish off the podcast. That's all for today. I'd like to thank Dr. Thompson, Dr. MacRae, and Dr. Bohm for joining me, and to all of our listeners for tuning in to another GREX podcast.